If I get a really bad question, I want to give it to you.
I have a comment. I work with hypnosis actually, and I treat very many people with fibromyalgia by hypnosis, and I saw you had just moderate evidence for hypnosis, but as far as I know, the response rate is like 70%, and I experienced that some patients respond very quickly, that it's almost like magical treatments, that 2-3 treatments and they say I am well. That the others respond slower and less, but actually, as I experience it, almost everyone responds. What is your comment?
So, a couple comments. One is, a lot of times when it says there's no evidence, it really means that there haven't been enough high-quality trials done to move something up the ladder. It doesn't mean that it doesn't work. It means there's a lack of evidence. And both my grading system and Winfried's grading system are at the level of evidence. So we're not saying that things that are not up at the top don't work. Now, but the other thing that I would say is that the plural of anecdote is not data. And anecdote is not very effective in figuring out whether a drug is working to treat pain. We have snake oil and copper bracelets and all sorts of things that over years have been, and opioids even, that were promoted as effective therapies for pain, that when they were more carefully studied, they turned out to be not. So you have to be very careful about translating the experience you have in clinical practice to what would happen if you subjected that particular intervention to a randomized controlled trial.
There are 2 new studies with better quality on hypnosis, and it's a new systematic review in European Journal of Pain published this year from our working group. But I agree with you, and the response rates in this randomized controlled trials are not as high as you see in your practice. So for me, in my personal approach, it's a part of self-management together with relaxation techniques and whatever helps the patients to come down and to relax. And we have some prepared and fixed audio tapes for fibromyalgia patients in Germany available. But this is a chunk to the main principles of aerobic exercise and perhaps drug therapy. It's not the main therapy, to my opinion, even if I'm a trainer in hypnosis.
Could I say one more thing? Because I think it's really important for people to take care of individuals with chronic pain. When we do trials, we talk about the placebo effect as being a negative thing because we compare everything to placebo, and if our active treatment doesn't do better than placebo, we say that it doesn't work. So in the context of when we're scientists and we're wearing our scientist hat, a placebo effect is bad. When I'm a clinician and I spin my hat around, I'm trying to maximize the placebo effect. I'm trying to do everything I possibly can in a non-specific way to get that patient to believe that they're going to get better, because I know if however I can get them to believe to get better, they can release their own neurochemicals. I don't have to give them a drug. They can release their own neurochemicals and do this in a more endogenous way. So let me say this, and I don't think I'm going out on a limb. You are probably a very charismatic provider in that you're really good at getting your patients to believe that what you're doing is going to be effective. And that is really important. And it's not in any way to be dismissed. It's incredibly important for us to do that and to maximize the placebo effect in clinical care. So you probably are, the results you're seeing are the results you're seeing, but the results you're seeing are the effect of hypnotherapy plus the placebo effect that you have been able to engender in your patients. And that's not bad. There's nothing wrong with that. It's what we should be doing.
will just mention a factor that I often see in studies, and I wonder about myself: patients' own satisfaction with the treatment, and not satisfaction with the efficacy or the anything. They just you have, for example, surgeries that have knee surgeries that have shown no effect whatsoever, and negative placebo. And if you ask a patient, and the control group with no effect, a negative effect, would say, "I would do it again." So sometimes it seems like patients like the treatment. I have also asked, I'm a physical therapist, but I asked them on NRS level, and I see that they have a lot of drugs, and I say, "I have a 9. Oh, that's bad. The drugs don't help." No, but I have to do something. So patient's satisfaction is a role that plays a big role.
Absolutely.
And a big problem.
The other thing you said, though, that I want to expand upon. Now I forgot. I'll think about it in a second. I know what it was. And when Winfried said this, but I want to expand upon it and focus on maybe one of the reasons why we do this. He said that when you're treating chronic pain patients, you shouldn't try to have the pain be the target to the patient. You should have functional status be the target. And all of us in the pain field agree with that. But one of the reasons for that is that you see a lot of people with chronic pain that what happens is you give them an effective intervention, and then all they do is they reset their 0 to 10 pain scale. They're clearly doing way more than after that knee arthroplasty. They're doing way more than and we're looking at them and we're seeing that they're functionally doing a lot better, but their pain score is the same. And it seems as though a lot of people just will settle into the most pain that I can tolerate is 5 out of 10 pain. But if someone is doing 3 times as much in their day-to-day life before they get to 5 out of 10 pain, I'm going to declare success. We're going to declare success because we've really dramatically improved their function. And that's another of the problems with focusing too much on someone's pain score as the endpoint that we're targeting.
Hi. Jeg har tre ting. Back to your knee. You talked about the knee. If you operate the knee, they wouldn't make any difference if they have fibromyalgia because they have pain everywhere. Then I'm wondering, if you have a knee pain and you have it for a long time and you are suffering for a long time, is it possible that you can develop into fibromyalgia because it's the same system? It's like a breakdown of the system. That's my first question. And,
so the answer to that is yes. That's a simple. When I was talking about the bottom-up form of fibromyalgia, the condition that we think most likely leads to that is osteoarthritis. That people start out by having a peripheral problem, but over time it becomes.
So it's stressful for the system. And
right.
Okay, unnskyld. And then I was thinking about there was something about the people. Okay, something about people born in 1940 or something, that they had more risk for getting fibromyalgia because of circumstances. And I'm thinking, is there any? Kids born under difficult circumstances in any form of way, like it could be pregnancy, it could be whatever. Diseases or whatever. Is there any survey or any tips for the parents so that they can prevent? Like you said, exercise is important, but maybe some kind of very good exercises you can target it, or you can find out if there is really a connection between it.
Okay. So I think the slide you were alluding to was a slide I showed, which talked about the 1958 birth cohort study.
Yeah.
And that was one of the best studies that did look prospectively at different things that happened to people and it turned out that the children, all the children that were born in the United Kingdom in 1 week in 1958 have been followed the remainder of their life. And they're still following about 70% of those individuals, which are age 59, because I was born in 58. I know I can do them without doing the math. And that's been a really good study for looking at how different things that happened to children early in their life then later affected their rate of developing pain. And that is one of the studies that showed that several different things that happened bad to kids when they were at age 8 made it more likely that they would have chronic widespread pain when they were adults.
Okay, and the last one is that I have that disease, fibromyalgi, and I'm thinking in the beginning, for many of us, it's very strong in the beginning. So, I mean, you're talking about treatment, and I mean, that is going over time, and it's a weaker way. So, I mean, when you are in so much pain, you can't exercise, you get ill of everything. I mean, then I think you must need some stronger medicine than what you are giving. I mean, you can't go to the gym. You can't go to work. You can't do nothing. I mean, for some people we are different, but I'm thinking there must be, and there is no knowledge. If you come to the doctor and say, "Oh, I have pain," "Oh, I go to the gym," but you get more ill. So I mean, as you said, there needs some education, of course. But I think, and you say, I got opioid over that period, so that helped me. Because I don't think there was anything else. That's what I'm saying. So, but because it was acute, it was an acute incident.
So I think this is a very important experience of many fibromyalgia patients. I know they are then to the gym, and then they suffer for 1 or 2 weeks from more pain. And that's why that just happened, because the kind of exercise is not adapted to the individual fitness level of the patient. And I see many patients which are with severe forms, and they have really, really very bad physical fitness. And sending these patients to the gym is a mistake. And they should start very slowly to make a slow walk. And then you can start with 100 meters and 200 meters the next week. And perhaps in 6 months we can send you to some aquatic exercise. And I think this is the art of the doctor, just to find out what fits to this patient.
Hello, I'm a physician here in Oslo, and I'm a rheumatologist, and I'm wondering, who do you think should treat patients with fibromyalgia in your experience? Are these patients who should go to their general practitioners and mostly just receive help from them, or is there a need for a specialist health care center and multidisciplinary centers? Yes.
So it depends on your healthcare system. So in our German guidelines, we said the patient should go to this type of doctor, irrespectively of the specialty, who is interested in fibromyalgia and have some experiences. This might be the rheumatologist, this can be the neurologist, also the family doctor. It depends. So if we are talking about a graduated approach, what I favor, to my opinion, and this is what we try to do in our center, that the slight forms of fibromyalgia, they should be with the GP, but with some clear recommendation of some specialists how to do exercise and which drugs to use. And I think most GPs in Germany, they can use amitriptyline. They know how to dose it and are familiar. And in contrast, the severe forms of fibromyalgia, they need, I think, a single person alone cannot manage it, and especially not rheumatologist, because you need a mental health care specialist in a team if you treat a patient with a severe form of fibromyalgia.
Yeah, I would agree. I think the rheumatologist's role in caring for fibromyalgia is to see that person once or twice, make sure that's the correct diagnosis, and then send back to hopefully a GP that can manage it. We don't have nearly as many interdisciplinary pain centers. Unfortunately in the US, most of the places that call themselves interdisciplinary pain center either do too many injections or they prescribe too many opioids. So there's no way I'm sending my patients to those. They'll get worse if we send them there. So it totally depends on how your healthcare system is set up and what it's designed to do.
I'm thinking a little bit about the new diagnostic criteria that includes a broader part of the population than the ACR 90. And you haven't talked anything or much about chronic fatigue or ME. Do you have any thoughts about how they would we would have more of these patients in the fibromyalgia pool, or whether they are very much overlap between the two, or what about treatment then?
The treatment is very similar. I just wrote an editorial in Lancet about graded exercise therapy based on the second or the third study, the really well done study in the UK looking at graded exercise therapy. And the type of graded exercise therapy that was done in those trials is almost identical to what Winfried's been talking about. It's really started at a really low level. Wherever that person happens to be starting at, you got to start out at that low level and go very gradually and very slowly. There's evidence for most of the non-drug therapies that we've listed would have in general, there aren't nearly as many RCTs done in chronic fatigue syndrome, ME, as there are in fibromyalgia. But most would really look very similar with respect to the list of non-pharmacologic therapies. And some of the drugs would probably be some of the drugs that you would use, but in people that don't have any pain, many of those drugs are inherently analgesic drugs. So the drugs that have more of an effect on fatigue, for example, the serotonin norepinephrine reuptake inhibitors, especially the ones that are more noradrenergic, would be the drug that I would use first in someone with chronic fatigue syndrome without any pain whatsoever. But most people with chronic fatigue syndrome have pain. They may not endorse as much pain in as many areas of their body, but if you look at the older criteria for CFS, 5 of the minor 8 criteria were pain. It was headache and tender and sore throat and muscle pain and joint pain. So it's not the case that chronic fatigue syndrome patients don't have pain. They often don't have as much pain and they have more fatigue or more memory problems.
One comment, the new criteria did not increase the prevalence of fibromyalgia in Germany. So we conducted a study with a representative population sample, and the prevalence was 2.1%, and with an equal sex distribution.
How does that happen? How do you add a whole, 50% more males and not increase the prevalence? Do you think it actually was taking people that, it had to then take women that in the 1990 criteria didn't meet?
No, so we just could use them because it's anonymous, the study. It's with a fibromyalgia symptom scale. So they were distributed to a representative population sample. And then we had this 2.1%.
I guess what I'm asking, though, is that 2% was the prevalence in the 1990 criteria. So all of those people that met the 1990 criteria were women. And you say half of the one that meet the new criteria are men. It must be the case, then, that half of the women that met the old criteria are not meeting the new criteria, or else your prevalence couldn't be 2%.
Yeah. So we had no study with a representative population sample with ASEAN 1990 criteria, and because this is nearly impossible to establish with the tender point examination. We have these studies with regional in regional areas of Germany, and then the prevalence was maximum 3%.
Okay, thank you. I've seen some more questions here. Write it down. There will be a wrap-up session by the end. We need some questions there, really good questions. And people, stay tuned. More highlights will come.